those areas and come up with an online toolkit within each of those topic areas that really helps get everyone on the same page moving in the same direction. Alicia's going to talk a lot more about that, but it's something, again, that we're very excited about. Start off by letting you know who our partners are. So Alicia and I are at the NORC, Walsh Center for Rural Health Analysis, and myself and Alana Knudsen are the co-directors of that office, and we are the lead partners on this evaluation project. We're doing it in partnership with the University of Minnesota Rural Health Research Center. Ira Moscovice, Michelle Casey, and Walt Gregg are the leads at the University of Minnesota. We've also partnered with a number of other organizations. 2 of them are assisting us in dissemination, so they help us get the good information that we're collecting out to the rural health community. Those would be the National Rural Health Association and the National Organization of State Offices of Rural Health. For those of you who have not connected with your state offices of rural health, I hope all of you have. But if you have not, know that each state has an office of rural health. And they are tremendous resources for all rural health activities within your states, and you should connect to those individuals. And then we're also working with the Rural Health Resource Center, which is a great organization that helps with rural health clinics around the country and helps provide technical assistance to them, and has been a really good resource for us in terms of how to implement some of the evaluation projects that we're looking at. So these are the programs that we're evaluating. So this is all of the programs under 330A Outreach Authority, and this was created as part of the Public Health Services Act in 1991, and nearly $500 million have been awarded since inception, and these have funded about 900 consortia, which have done a number of things, not the least of which are to expand access to healthcare services, coordinate resources, and improve quality of services in rural communities. A lot of these programs really aim at creating networks of community participants, community providers to improve services within the community. There are currently 6 programs that are funded under this authority. They're the Rural Health Care Services Outreach Program, the Network Development Program, the Network Development Planning Program, the Rural Health Network Development Program. Those are a little confusing because they sound similar. One of them is a small program to get your network up and running. The other one is a larger implementation grant. Then the Small Healthcare Provider Quality Improvement Program, which we're all very familiar with. The Delta States Rural Health Network Program, which is also a network development type program targeted in the Delta region. And then there's a newly established program, which is the Rural Health Workforce Development Program, which is another network development type program focused on workforce development activities. And then again, I mentioned that each year within our contract, we are doing a series of projects. We have an advisory committee that helps us come up with ideas for good evaluation activities, good projects to look at across the 330A programs. And then we work very closely with the Office of Rural Health Policy to determine which of those ideas we should move forward. In this first year, we did, again, 4 projects. And I'm going to go through each of these briefly. Actually, I'm going to go through 3 of them briefly, and then Alicia's going to go in a lot of detail on the 4th. These were projects to look at strengthening the Network Development Planning Grant Program, and a lot of that looked at the sustainability activities of grantees. Another was to look at the Performance Improvement and Measurement System database. This is the data collected by the Office of Rural Health Policy. We wanted to look at that data both to analyze it and to offer recommendations back to the office for strengthening the data collection so that it can be more robust and analyzed more effectively moving forward. And then we have a project where we are looking for common evaluation metrics across the outreach grant programs. I'll tell you more about that. And then again, Alicia's going to talk about the Evidence-Based Toolkit series, the first topic of which was on community health workers. So you had a nice introduction to that in the last session. So again, briefly, I'm going to go through really 2 slides on each of these. This first project was led by our partners at the University of Minnesota. The goal was to assess the extent to which the 2006 to 2008 Rural Health Network Planning grantees had sustained operations to address local healthcare needs. The methods that they used was to convene a panel of rural health network experts, develop a phone survey in collaboration with their expert panel, to collect information on the grantees, and then to review and analyze the results from those telephone surveys. And the findings on this one I thought were pretty stunning, because I think a lot of us think about these small grants, and this is an $85,000 grant program, 1 year to implement, and we think, well, funding goes away after that year, what happens to the program? Well, what they were able to find is that for 40 of the programs that they were able to, or 50 of the programs that they were able to track, 40 of them were still in operation after the grant funding had ended. So 80% of them were able to sustain operations after this relatively small investment. It really speaks to the power of seed funding and getting networks together, and once you get people together, these things can truly create a life of their own. Of the 40 that were continuing in operation, 75% of those had actually expanded their networks. So they'd actually grown and brought in new partners after the funding had ended. Again, I think this is a real dramatic success story. And then 9 of the 10 remaining networks reported having a formal governance structure. So all of these very positive type findings. Again, I'm going to go through these quickly. So then the PIM system, and I teed this up a little bit for you. This is the measurement system that's implemented by the Office of Oral Health Policy. All of the grantees submit their performance information into this system. The project goal was to analyze the PIMS measures and then develop recommendations for the office to ensure consistent reporting and facilitate future analyses. The office had done, I think, a really fantastic job of getting those initial sets of measures together. It is a very difficult task, and once you start to collect that information and see where are the holes and what people are able to report, you can go back in to figure out how can we make sure that people can more easily report this information. And that's where our recommendations really were intended to help inform the future. So in terms of methods, we cleaned the PIMS data and developed a code book so that we could facilitate that analysis. We developed a quantitative description of the different programs, so we did those analyses, created a number of descriptive statistics on the programs, and then again, we identified the areas for improvement. Briefly, some of the findings, there are some simple things that we recommended, such as coding changes. So things as simple as having a not applicable category versus a 0 category, because 0 actually can be an answer. You can report that you didn't have any participants, 0. But sometimes people, when there's not a not applicable, they'll put a 0 in just because they feel they should put something in that can skew the findings. So simple things like that were recommendations that we had to increase the robustness of the system. We suggested that they consider developing variable definitions and then adding skip patterns so that if something doesn't apply to a set of grantees, they can move on to the next thing. And then this is just a sample. I believe this one was from the Network Development Planning Program. Just as a sample of the kinds of analyses we did, you'll see that within this, for each successive year, grantees actually improved their performance on these different measures. So again, this is the kind of finding that you're looking for. So we were also, with the current data, able to come up, I think, with some really good findings on how programs are moving forward and improving their reporting. And then the third program from last year was our Identifying Common Evaluation Metrics program. This is, I think, a fairly complex project that we took on. It is a multi-year project. The intent was in the first year to use one grant program as a pilot and then expand this to the other grant programs over the future years. The idea was to look for common data elements collected through grantee level evaluation activities. So what we did, and we started this with the Delta grantees, we gathered all of the documentation from the Delta grantees, from their applications to their regular reporting to internal evaluation activities, and within each reporting cycle or document, we pulled out every very specific metric that they were collecting, and then we created this very large database and tried to identify what metrics our grantees capturing in common with one another, because those are the data points at which you can compare different grantees. And then the intent is to do this for each of the remaining programs over this next year, and then look not only within each program and have very specific measures for each program, but also look across the programs to say, how does this body of work within the 338 program, how can we analyze what's going on broadly across all these different programs? And I think that's an ambitious goal, but I think that there are going to be a number of measures that really do cut across the grantees. And then the next step is to look back at those PIMS measures to say, if these are the metrics that can be captured across grantees, are they currently included within the PIMS system? And if not, here's some recommendations for future measures that can be added. I kind of described the methods as I went through that. We looked through the grantee documents, developed this database. We interviewed grantees then to confirm all of those findings to make sure that what we had pulled out of their grant documents, the grantee documents, really was information that they could report. And then we analyzed that database to look for those common measures. Again, the year one focused on Delta grantees. What we found was that there was one measure and only one measure that cut across all of the grantees, which was the numbers of people served. But there were 5 other measures that were found to be collected among most of the majority of grantees. Those included number of events, number of screenings, total encounters, number of residents receiving health education, and number of patients served. One of the things that you should know about the Delta Grant program is that there are 12 grantees, and really those 12 grantees fall into 3 distinct categories. Some are school-based programs, some are clinic-based programs, and some are community-based programs. So within this one relatively small program, we actually had different types of activities that really had different target audience. So it was a nice test case for how do you collect common measures across disparate types of programs. And then here's what we're going to be doing in the next year, which is the current year, actually. We're continuing the Rural Health Network Development Planning Grant Program. This is the first one I've presented to you, which is being done by Minnesota. There is a new set of grantees, and we're pulling their data in and looking at their sustainability as well so that we can expand upon the data that's been collected. We're doing the full rollout of the Common Metrics program. We're also doing a small evaluation of the Rural Access to Emergency Devices project. And then we're doing baseline collection for the new Workforce Network Development Program, and that's going to be part of a 3-year project that we're taking on to really look at that program in a very robust way. And then we're doing the second in our series of evidence-based toolkits, which is the Obesity Toolkit. And then the other thing that we've been very actively doing is trying to disseminate the information that we've been collecting. We've been giving quite a few presentations at NOSOR meetings, both nationally and regionally. We have been presenting each year at the NRHA conference, and then we've been presenting to grantees at meetings such as this. We also had in the last month of Rural Roads, I don't know how many of you are members of the National Rural Health Association, but each month they put out a glossy magazine called Rural Roads. We had an article featured on the work of the evaluation activity, as well as the community health worker program specifically, as part of the evidence-based toolkit. And then we've been doing a number of requests for information to gather more information about these different programs. And then the last thing, which may be the most important thing, is the Rural Assistance Center. I hope all of you are familiar with the Rural Assistance Center as well. The website is raconline, raconline.org, and it is housed at the University of North Dakota, and it is really a one-stop shop for everything rural health. There is a wealth of information that will help all of your programs in there, but the reason I mention it here is that they're also one of our dissemination partners, and all of the information we're collecting from the evaluations in general, and more specifically as part of these toolkits, which Alicia is going to talk about, is being housed on the Rural Assistance Center website. So please go there, you'll find this information shortly as it gets uploaded. And with that, I'm going to hand it over to Alicia to talk about the evidence-based toolkits.
Thank you. Good morning, everyone. I'm going to be talking about our approach to building these toolkits, how they can be used in your communities, and I'm also going to be talking about some findings from our first toolkit in year 1 on community health worker programs. An evidence-based toolkit is a compilation of evidence-based resources and practices from from the literature and the 330A grantees. And the intention of the toolkit was to document evidence-based practices that could be related to different rural health issues and initiatives. For this project, we define evidence-based practices as those that have been found to be effective based on the results of rigorous program evaluations. And we're developing one toolkit each year on a different topic. So in year one, we did community health workers. In year two, we're focusing on obesity prevention. And the audience for the toolkits are the grantees, future applicants, and other rural communities. And so the purpose is for folks to be able to adapt the evidence-based models to their programs and also to adapt resources that have already been developed by communities so that they don't have to reinvent the wheel. And they recognize that everyone has a different level of knowledge on a topic and also is in a different place in their program implementation. So the toolkits will be helpful no matter where you're at in that process. And they're going to be publicly available on the Rural Assistance Center website. So why are we building these? We're building them because ORHP is working to align evidence-based approaches and grantee program activities. And by doing so, by identifying these approaches and disseminating them in the community, we can help to facilitate the replication of programs that are grounded in research and experience. And we also think the toolkits will be helpful from a sustainability perspective. Building programs that are based on evidence can help grantees to justify the continuation of their funding and also to obtain new funding because they can show that their model is, it can reduce outcomes or it can achieve other important outcomes. I want to acknowledge our evidence-based toolkit project team at NORC. And I'm going to run through the 5 steps that we use to develop the evidence-based toolkits. The first is that ORHP identifies a priority rural health issue or initiative. And so in year one, we did CHW programs, and I'm going to be talking about that. The review of literature was the second step. And so we conducted a review of the gray and academic literature on the topic, and we identified evidence-based models and resources. Then we identified grantees within the portfolios that are working on a program related to that topic. And then we explored whether their activities aligned with the models we identified in the literature. And then finally, we developed an evidence-based toolkit, and we posted the resources on the REC website. So I'm going to take you through each step using community health workers as an example. The rationale behind choosing community health workers was that they're a strategy being used in rural communities. We heard some of that in the last session. And they're also being used by several of the grantees. There isn't a consistent definition in the literature on community health workers, and there's little information out there to establish proven programs, so it's an important topic. As a result, rural communities are developing CHW programs from the ground up when really they could be using resources that have been developed already to help begin those programs. So the hope is that this toolkit and the toolkits that follow it will help to disseminate those resources in the field. The second step is reviewing the literature, and we did this to identify evidence-based models and resources. And the first thing we did was to identify all of the different definitions on community health workers in the field. We found that there are many different definitions, and the one I want to share with you is from the CHW National Workforce Study coming out of HRSA in 2007. And it says that community health workers are lay members of their communities, paid or volunteer, who work in association with the local healthcare system. They share many of the same characteristics as the target population they serve, from life experiences to ethnicity, language, socioeconomic status. And they may provide a range of services, from interpretation and translation to providing informal counseling or guidance. And some of the models actually also have community health workers providing basic health services. Our literature review also found that CHWs are being used in many different ways in communities across the country. And essentially they're being used however they can best meet the needs of their target population. Some of the other titles used are community health advisors, lay health advocates, promotoras, outreach educators, community health reps, peer health promoters, and peer health educators. So during our literature review, we identified some promising approaches on community health workers in rural areas. And I want to spend a moment talking about why we're calling them promising approaches and not evidence-based approaches, because it's an evidence-based toolkit. If you think about an evidence-based approach on a continuum where you have no evidence and full evidence, the body of literature on rural CHW programs is somewhere in the middle. And so I think it's important to make that distinction. And from our literature review, we found that I think this is for two reasons. Part of it is because community health workers are defined in so many different ways, and they're used in so many different ways in communities. So that lack of consistency can create challenges for developing that evidence base. Another challenge is that often these programs are not rigorously not rigorously evaluated because of a lack of time or a lack of staff with evaluation expertise or funding. And so without evaluation, it's very difficult to demonstrate the effectiveness of these programs and to build that evidence base. So just to go through a few of the promising models that we identified in lieu of evidence-based models, we have CHWs as a member of the care delivery team, and that's where they provide case management with a lead provider, or sometimes they will provide screening while the provider provides other services. They also serve as patient navigators, where they assist individuals in navigating the healthcare system or the services that are available in their communities. They serve as screening and health education providers, where they work with individuals who have chronic disease or other special health condition in terms of accessing screenings or other care methods. They also serve as outreach and enrollment agents, where they go out into the community, they identify individuals who are eligible for different programs, and they help to enroll them. And finally, CHWs also serve as community organizers and capacity builders, where they promote community action around a specific topic. And these are commonly more volunteers than paid workers. So after our literature review, we identified 7 of the 338 grantees that are conducting a community health worker program or in the process of implementing one. And we developed an abstraction template, which we use to review their program applications and to learn a bit more about what they're doing. And then we developed an interview protocol, which we used to conduct 1-hour interviews with 6 of the 7 grantees. And during these interviews, we used them as an opportunity to ask them about their program approaches. Did they use an evidence base? How did they identify their community health workers? What were some of their outcomes? What were some of the implementation challenges? So it was a great opportunity to hear some of the work that's going on. After these interviews, we assessed whether the grantee projects aligned with any of the models that we identified in the literature. And we found that all of the programs had a health education model or component where the CHWs provided health education in the community. Many of them had an outreach and enrollment component where they conducted some structured outreach. And we found all of the programs blended the different models which I discussed, so no 2 programs were alike. And just to give you a sense of a couple of the grantees, there was one grantee out of Texas who aimed to increase participants' access to healthcare services and knowledge about different health education topics. And this grantee used both community health aides and promotoras in their program, and both of these could be considered community health workers. So in this program, the promotoras met with individuals in the community, and they conducted group education on nutrition and exercise topics. And the community health aides went door to door in the rural border communities in Texas and talked with families about their health concerns, whether they could make any referrals for them, and tried to provide more structured outreach. So in this program, the models were the promotora model, the health educator model, and the outreach and enrollment model. Another grantee out of Mississippi worked to improve health outcomes for patients in community health centers that had just been diagnosed with a chronic condition. And this grantee conducted a number of services for these patients. They worked with community health workers to arrange transportation assistance to medical appointments. They enrolled them in benefit programs. They provided health education to patients and their families. They also provided education to families to help to improve health status for their patients. And they worked with pharmacists to improve medication compliance and management. So really a range of services. And this particular grantee, I would say, implemented a health educator model, an outreach and enrollment model, and a care coordinator, care manager model. So as you can see, the grantees are using these different models, but in very different ways. So the final step in the process was actually building the toolkit, and that's where we're at today. It's very exciting. We're in the process of getting that up on the RAC website to share with all of you. And the first step was that we reviewed and organized all of the resources that we pulled from the literature and that we identified through the grantee interviews, because many were very gracious and gave us a lot of their templates and sustainability plans or different documents that could help other communities. We developed a modular structure for the toolkit where each module represents a different topic related to community health workers. And then within each of those modules, if you click through, you come to a series of questions and answers so you can find the exact information that you're looking for. And then within those questions and answers, we provide a series of templates or resources that could be helpful to you as well. So we are currently in the final stages of developing that toolkit. And the toolkits are going to be part of a new section on the RAP website called the Rural Community Health Gateway. And you should look for those within the next few months. So just to give you a sense for what the CHW toolkit is going to look like, it has 8 modules. The first is an introduction to community health workers. So who are they? What are their roles? How might you use them in your community? Module 2 talks about the program models, which I discussed. The third is on training approaches. How do we train them? Are there certification programs in your state? Are there curricula that other grantees have developed that you could adapt? The fourth module is on program implementation. What do you need to consider before you recruit or hire a CHW? Are there liability issues that would relate to your program? Are there implementation challenges? The fifth is on planning for sustainability. As was mentioned earlier, sustainability is a really challenging topic, and we've been able to identify some templates and resources that hopefully will be of use to many of you. And the sixth is on measuring program impacts. So how do we evaluate these programs? What types of quality metrics are available to evaluate CHW programs specifically? The seventh is on dissemination resources. So once you have a program, what are some of the vehicles that you could use to get your program findings out into the public domain? And then the eighth is a program clearinghouse where we're including information about current grantees that are implementing CHW programs in rural areas. So here's a screenshot of the CHW toolkit. And as you can see, you would just click on those red module links and they would take you over to another page that has questions and answers and resources. And then finally, I just want to spend a moment talking about the Obesity Evidence-Based Toolkit, which is our Year 2 project. We have already started working on this, and there are many reasons why obesity is an important topic to focus on. Rates of obesity have increased dramatically over the last 3 decades. The rates in rural areas are particularly high, with 20% of rural adults and 20% of rural adults compared to 18% of urban adults obese. And then the statistics are 17% of rural children compared to 14% of urban children. The evidence-based or community-based models of obesity prevention are still being compiled. And there's little information out there about proven approaches in rural areas. And so I think this is a great opportunity to review the literature and the experiences of the grantees and see what types of resources we can make available. Additionally, we're conducting the review of literature component right now, and we're looking at both rural and urban approaches to obesity prevention. We're looking at school-based, clinic-based, and community-based models. We've identified 9 of the 338 grantees that are doing an obesity prevention program. And we've conducted interviews with 6 of them at this point, and I think we have a few more scheduled. Also, we're going to be interviewing some non-ORHP grantees to get a sense for other projects that might be going on in the field. And so our next steps are very similar. We're going to explore the alignment between the models that the grantees are using and the models we've identified in the literature. And then we're going to develop probably a very similar structure for the Obesity Prevention Toolkit with different modules. And then we will implement it on the REC website. So I guess I will just pause and see if anyone has any questions or comments about the toolkits. I would love to hear about future ideas for toolkit topics. And I want to urge you, if you do have resources related to community health worker programs, and it sounds like many of you do, I would love to talk with you, and I would love to get some of those resources for the toolkit. Similarly, if you are working on an obesity program or you have any resources that you think would be helpful, we would love to get those as well. So I'll pause. Oops. Does anyone have any questions for us? Okay, thank you very much.